Imagine beating cancer. I mean, you've gone through just grueling rounds of pelvic radiation, you finally hit remission, and you're ready to reclaim your life.
Right, the hardest part is supposed to be over.
Exactly, but there's this lingering, incredibly painful side effect from the actual treatment. So you see an ad for this widely popular FDA-cleared medical device.
And it promises to heal that exact type of pain.
Yeah, precisely. So you go to a clinic, you get the treatment, and instead of finding relief, you end up with severe internal burns and, permanent scarring.
It's a completely devastating scenario. And honestly, it all comes down to a fundamental misunderstanding of human biology.
Right.
We really want to believe that a machine with a high success rate
Mhm.
is just this, universal fix. But the physical reality of surviving cancer, it completely rewrites the rules of how your body responds to therapy.
Well, welcome to today's deep dive. We are sorting through a massive stack of medical literature today. We've got clinical consensus statements from the American Urogynecologic Society, AUGS, some pretty severe warnings from the FDA, and oncology guidelines from ASCO.
Yeah, it's a lot of heavy but really important source material.
It really is. Because if you've been paying attention to women's health lately, you've probably noticed the absolutely booming market of energy-based devices.
Oh, yeah. Specifically radiofrequency or RF.
Right. Used for vaginal health and, rejuvenation.
It is everywhere. I mean, you
Yeah.
can hardly open a lifestyle magazine or go on social media without seeing an ad for it.
Right. But our mission for today's deep dive is highly targeted. We are focusing specifically on cancer survivors. We want to understand exactly how pelvic radiation fundamentally alters the hidden biological landscape of vaginal tissue.
Which is a very specific, unique environment.
Exactly. And more importantly, we're going to explore why that alteration radically changes how that tissue responds to those popular RF treatments, basically turning a potential cure into a massive risk. Okay, let's unpack this.
Right. So to really understand this biological clash, we first have to recognize the sheer momentum of these devices right now.
They're incredibly popular, yeah.
They are. Because for millions of women experiencing general menopause, radiofrequency devices are heralded as like a non-surgical miracle.
For GSM, right, genitourinary syndrome of menopause.
Exactly. When estrogen drops naturally, tissue becomes thin, dry, and painful. And for those typical cases, RF is incredibly effective.
Okay, but for the cancer survivor who has had pelvic radiation, using that exact same wand is highly contraindicated.
Right. It's a completely different ballgame.
So if you're listening to this, the obvious question is, why does a cure become a curse just because of your medical history?
Which is a great question.
Right. To grasp why RF fails so spectacularly in irradiated tissue, we really need to know what it's actually doing when things go right. Like, what is RF designed to do in healthy, typical menopausal tissue?
Well, let's break down the mechanics. Radiofrequency is basically a type of low-frequency electromagnetic energy.
Okay.
The devices used in these clinics, they typically operate at around 450 kilohertz.
Wait, 450 kilohertz, that sounds kind of intense.
Right, it sounds like a lot, but on the electromagnetic spectrum, it's actually incredibly slow and very low energy.
Oh, really?
Yeah, it's roughly 1 billion times lower than an X-ray, for example.
Okay, that feels like a really crucial distinction to make early on, because when we hear the words energy or, radiation, our minds immediately go to danger.
Of course they do.
But this is an ionizing radiation. It's not like scrambling your DNA. It is essentially just producing heat, right?
Correct. Yeah, it's creating a very specific, controlled thermal stress.
Yeah.
But it does this in a completely different way than the other popular devices out there.
Like laser.
Right, exactly.
Yeah, our sources mention CO2 and ERYAG lasers quite a bit. And from what I'm reading, those lasers basically act like a tiny, high-tech sandblaster.
That's actually a really good way to picture it.
They vaporize the superficial surface of the tissue, creating these microscopic injuries to force the body to heal the surface.
Yeah, lasers are ablative. They target the water in the very top layer of the tissue.
Right.
But radiofrequency, because of its longer, slower wavelength, it essentially ghosts right through that surface mucosa.
Oh, wow. It just passes right through.
Exactly. It penetrates much deeper into what we call the fibromuscular layer.
Okay, the fibromuscular layer.
Right, which is the structural support system, the scaffolding, basically,
Yeah.
of the vaginal wall. And it does this without burning the top layer.
Okay, wait. I mean, if we are driving microwave-adjacent energy deep into the pelvic floor, that sounds like trying to bake a cake from the inside out.
It does sound pretty risky when you put it like that.
Right. If you're bypassing the surface and pumping heat into the deeper structure, How are patients not getting severe internal burns?
Well, that is the multi-million-dollar engineering question right there. The secret is the temperature control.
Okay.
The FDA-cleared devices are equipped with these highly sophisticated thermistors. Basically, continuous temperature sensors built directly into the wand.
So it's constantly checking itself?
Yes. They monitor the tissue millisecond by millisecond,
Mm-hmm.
and that's to ensure the internal temperature never exceeds 42 degrees Celsius.
Which is about, what, 107 degrees Fahrenheit?
Right around there here.
So it's warmer than body temperature, but not quite boiling.
Right. It heats the tissue just enough to cause a specific biological panic, but it stops right before it causes actual cell death.
And that controlled panic, that's the magic trick. Because when the tissue hits that exact 42-degree mark, what exactly does the body do?
It initiates this massive rescue operation. When you heat those deeper connective tissues to that exact therapeutic window, the body releases heat shock proteins.
Heat shock proteins. Okay.
Yeah, think of them as the cellular first responders. They trigger a controlled inflammatory response, which basically wakes up your fibroblasts.
Okay, let's pause on fibroblasts because they are really the star players in this entire deep dive.
They absolutely are.
They're basically the tiny construction workers inside your tissue, right?
That's a perfect analogy. Fibroblasts are the cells responsible for building and maintaining the structural matrix of your tissue.
Okay.
In normal menopause, because of that estrogen deprivation we talked about, those construction workers essentially go to sleep,
They just clock out.
pretty much. The tissue thins out, blood flow drops, and everything just becomes really fragile.
And so the RF heat is the alarm clock.
Exactly. The heat wakes them up, and they get straight back to work. And they do three very specific things once they're awake.
Okay, what do they do?
First, they produce fresh, organized collagen to give the tissue structure.
Right.
Second, they produce elastin to make the tissue flexible and stretchy again.
Got it.
And third, they stimulate the formation of brand new blood vessels, which brings natural moisture and nutrients back to the area.
So taking a step back, in a typical patient, RF is a deeply penetrating heat that tricks the body into rebuilding its own plumbing and scaffolding.
Beautifully put, yes.
But, and this is the massive but of today's deep dive, that entire process relies completely on the assumption that you have healthy, functioning construction workers just waiting to be woken up.
Which brings us to the real pivot point of the whole issue today.
Right.
Because if a medical treatment requires a healthy cellular response to work, we really have to look closely at what happens when we apply it to a biological environment where that response has been fundamentally broken.
Okay, let's shift our focus to the survivors. We're talking about people who have survived cervical, colorectal, endometrial, or anal cancers.
Right.
And part of their life-saving treatment was targeted pelvic radiation. What does that radiation actually do to the tissue environment?
Well, the clinical oncology guidelines from ASCO detail this beautifully, though. I mean, it is a really harsh reality.
Yeah, definitely.
When a patient receives pelvic radiation, the goal is obviously to destroy the cancer cells. But there is just unavoidable collateral damage to the healthy tissue caught in the crossfire.
It's basically a blast zone.
Exactly. And this leads to a complex condition known broadly as pelvic radiation disease.
When I was reading the sources, I was really struck by the fact that this isn't just a temporary side effect.
No, not at all.
It's not like a sunburn that just peels and fades away once the cancer is gone. It triggers something called radiation fibrosis syndrome, which is a progressive chronic disease.
Yeah, and the timeline of this syndrome is what makes it so insidious. It doesn't happen all at once. It unfolds in these distinct phases over time.
Okay.
The very first thing that happens, the acute phase, is severe damage to the endothelial cells.
Endothelial cells, those are the delicate cells that line the inside of all your blood vessels, right?
Yes.
So the radiation essentially blasts the internal lining of the plumbing in the pelvic region.
Exactly. And when those endothelial cells are damaged, your body panics. It literally thinks it is bleeding out internally.
Oh, wow.
So it kicks off a massive coagulation cascade.
Meaning it starts clotting.
Right. The body starts dumping this clotting protein called fibrin all over the place. It plugs up all the micro blood vessels in a desperate attempt to stop a hemorrhage that isn't actually happening.
That sounds incredibly destructive to the local blood supply.
It is. It's
Yeah.
devastating. But it gets worse over time.
Ah,
The radiation also leaves behind a state of chronic oxidative stress.
okay.
And this stress essentially bathes the local cells in inflammatory signals, specifically something called transforming growth factor beta.
Let's translate that for you, the listener. What is transforming growth factor beta doing in this context?
Think of it as a chemical panic button that gets stuck in the on position.
Just constantly ringing.
Yes. Over time, sometimes months, sometimes decades after the cancer is actually cured, that constant alarm signal forces our normal, healthy construction workers, the fibroblasts, to undergo a mutation.
They mutate.
Yeah, they transform into something called fibrocytes.
Fibrocytes. Okay, how is a fibrocyte different from a healthy fibroblast?
Well, a healthy fibroblast builds a nice, neat, flexible matrix.
Hmm.
But a fibrocyte, it goes completely rogue.
Yay.
Driven by that stuck panic button, it starts frantically overproducing massive amounts of dense, rigid, totally disorganized collagen.
If I'm picturing this correctly, it's like scar tissue going into extreme overdrive.
Exactly.
It's like a biological concrete being poured into the tissue, actively choking off whatever blood supply is even left after the clotting.
That is the exact physiological reality of it. You have blood vessels damaged by the initial radiation, and then whatever is left gets choked out by this biological concrete.
Wow.
The patient develops accelerated peripheral vascular disease in that specific region.
And what does that mean for the patient physically? The ASCO guidelines use the medical term vaginal stenosis, but what does that actually feel like?
Well, it is a stark contrast to normal menopause.
Mm-hmm.
Normal menopause just thins the tissue, but radiation actively traumatizes the structure.
It's an injury.
Right. Vaginal stenosis means the vaginal canal literally becomes shortened, severely narrowed, completely dry, and entirely loses its elasticity. The tissue is essentially locked in a chronic state of inflammatory scarring.
Here's where it gets really interesting. If we hold these two ideas up against each other, the clash is just glaring.
It really is.
We established that radiofrequency therapy works by delivering deep, intense heat to stimulate collagen production. But you just explained that irradiated tissue is already suffering from a runaway, unstoppable overproduction of rigid collagen.
You've hit the nail on the head. When you take an RF wand and apply it to an irradiated pelvic floor, you are asking a broken biological system to perform a really delicate task. RF is designed to trigger healthy fibroblasts. But in this tissue, you don't have healthy fibroblasts anymore. You have mutant fibrocytes that are currently drowning the tissue in scar tissue.
So instead of graceful remodeling, what happens? Do you just make the scarring worse?
You absolutely risk severely accelerating the fibrosis. But, it's actually the heat itself that poses the most immediate dangerous threat.
Right, let's talk about that 42 degrees Celsius heat being pumped in. If the tissue is already scarred and the blood vessels are choked out, where does the heat even go?
Well, think about how a car engine works. An engine generates a tremendous amount of heat, right?
Sure.
But it doesn't melt down because it has a radiator system pumping fluid through it to carry that heat away.
Right.
In human tissue, your vascular network, your blood flow, acts as your biological radiator.
Oh, wow. Okay, so when the RF wand drives heat into the tissue, it relies on your blood flowing through the area to whisk the heat away and prevent a burn.
Precisely. Blood flow dissipates the thermal energy. But in a cancer survivor with radiation fibrosis, that vascular network has been destroyed.
The plumbing is clogged with fibrin and choked by biological concrete.
Exactly. The radiator is broken.
Which means the 42-degree heat just sits there.
Yep.
It builds up and builds up because the body physically cannot cool itself down. The very safety mechanism that makes RF viable for a healthy patient is completely neutralized in a cancer survivor.
And that causes the risk profile to just skyrocket. It is a perfect recipe for serious thermal injury.
It's terrifying because this isn't just a theoretical debate happening in some laboratory. This is a massive clinical danger.
Absolutely.
Which brings us to how the medical community and the FDA are handling it. Because if you're a consumer, the marketing for these devices is aggressive.
Very aggressive.
They are sold as lunchtime vaginal rejuvenation, and the ads certainly don't feature complex warnings about fibrocytes and vascular heat sinks.
No, of course not. The marketing is absolutely outpacing the science, which forces regulatory bodies to step in and throw up massive red flags.
Yeah.
The American Urogynecologic Society, AUGS, they released a very firm clinical consensus statement on this.
I was looking at Statement Q32 from their guidelines, and it is surprisingly blunt for a medical document.
It really is.
It explicitly states that there is no evidence to support the use of vaginal EBD therapy for the treatment of pelvic radiation-induced vaginitis. None at all.
And they stress that the long-term risks are entirely unknown. You just cannot take safety data from a healthy postmenopausal woman and blindly apply it to a cancer survivor whose tissue has been fundamentally altered.
It's comparing apples and oranges.
Exactly. In fact, if you look at the manuals for the legitimate RF devices, the manufacturers themselves list prior pelvic irradiation as a strict, hardline contraindication.
But the problem is that these machines aren't just sitting in highly specialized gynecologic oncology wards.
No, they're not.
They are being sold to med spas, aesthetic clinics, and practitioners who might not understand the deep biology of radiation fibrosis.
Right, and that lack of understanding leads to tragedies,
Right.
which is exactly what forced the FDA to step in back in 2018.
The FDA issued a severe public warning specifically targeting the off-label use of these devices for vaginal rejuvenation.
And they didn't just issue a gentle reminder either. They cited severe adverse events that were being actively reported in their Moyo database, which tracks medical device issues.
The case studies mentioned in our sources are genuinely heartbreaking. I mean, you have women who fought and survived cancer who were simply seeking relief from the pain of intimacy, and they trusted these energy treatments.
Yeah.
And instead, the Mayu database shows them ending up with massive internal scarring, severe vaginal burns, and crippling pelvic floor spasms. Some even developed crescent-shaped fibrotic bands that entirely blocked the vaginal canal.
It's horrible. And it highlights a profound medical responsibility.
Mm.
Because, look, RF has incredible data backing it up for general postmenopausal GSM. It genuinely improves the vaginal health index and female sexual function scores for healthy populations.
But lumping radiation survivors into that exact same treatment category, just because their surface symptoms of dryness and pain look somewhat similar, is a catastrophic oversimplification.
It really is.
You can't let this shiny promise of a new techno-wand override the physiological reality of radiation fibrosis.
Treating a radiation survivor requires the fundamental understanding that their tissue is not just, aging naturally. It has survived an active, life-saving trauma.
So if you are listening to this and you've been through pelvic radiation, or you know someone who has, and RF is strictly off the table, what are the actual options?
Right, what can you actually do?
Because we can't just leave survivors suffering from severe stenosis with no recourse. What does the evidence-based source materials say they can actually do?
Well, while there is no quick-fix laser or wand, there are highly effective evidence-based alternatives. But they focus on long-term mechanical rehabilitation rather than a sudden thermal shock. The absolute gold standard for treating and preventing radiation-induced vaginal stenosis is the regular use of vaginal dilators.
The ASCO oncology guidelines are actually very specific about the protocol for this. They recommend using smooth, medical-grade plastic or silicone dilators 2 to 3 times a week for 1 to 3 minutes at a time for at least a year after the radiation treatment ends.
Yeah, it is mechanical rehab. By gently, consistently stretching the tissue, you are actively fighting the fibrocytes.
Oh, interesting.
You are physically interrupting them as they try to pour that biological concrete.
Right.
It prevents the collagen from cross-linking and permanently shrinking the canal. It definitely takes patience, but it is incredibly effective at maintaining the elasticity of the tissue.
And there was a fascinating preventative measure mentioned in the sources from the MD Anderson Cancer Center. They found that if a patient uses a specific dilator during their actual daily radiation treatments, it changes the game entirely.
It's a brilliant use of basic physics, honestly.
Yeah.
They use the dilator as a physical spacer. By inserting it during the actual radiation simulation and treatment, it physically pushes the delicate vaginal mucosa away from the highest intensity of the radiation beam.
The sources noted that using that spacer decreased the radiation dose to the vagina by 5.5 gray. Now, for anyone listening who isn't a radiologist, what does a reduction of 5.5 gray mean in real terms?
In the world of oncology, that is a massive tissue-saving reduction.
Really?
Oh, yeah. By shielding the tissue from that much radiation up front, you are drastically reducing the initial endothelial damage.
So less broken plumbing.
Exactly.
Yeah.
Which means less coagulation, less oxidative stress, and a huge reduction in late-stage scarring and stenosis. You are basically stopping the cascade before it even starts.
That is such an incredible proactive approach. Now, beyond mechanical dilators, the sources also discuss local estrogens. But I know that for a lot of breast or gynecologic cancer survivors, the word estrogen is terrifying.
Understandably so, especially for hormone receptor-positive cancers. But the clinical guidelines are clear on making a distinction here.
All right.
Local, vaginally applied estrogens, like a low-dose cream or the estring ring, They stay highly localized to the pelvic tissue.
Meaning it doesn't flood the rest of the body.
Right. Once the initial minor tissue tears heal, the systemic absorption into the bloodstream is virtually negligible.
Okay.
It doesn't significantly raise your overall systemic estrogen levels above a normal postmenopausal baseline. So for many survivors working closely with their oncologist, local estrogen is a perfectly safe, vital tool to restore moisture and reduce pain.
And for those who absolutely, categorically cannot use hormones, there are heavy-duty, non-hormonal moisturizers.
Yes, exactly.
The sources specifically highlight those containing hyaluronic acid, which binds moisture to the tissue, providing significant relief. Plus, there is pelvic floor physical therapy.
Well, that's a big one.
A specialized therapist can manually help release the hypertonic muscle spasms that so often lock up the pelvic floor after radiation.
And, all of these options require multidisciplinary care. An oncologist, a urogynecologist, and a pelvic floor physical therapist all communicating with each other.
It's a team effort.
It really is. It requires a nuanced respect for the patient's unique cellular biology.
So what does this all mean? If we step back and look at the whole picture, radiofrequency is undeniably a powerful innovation. It uses targeted heat to wake up fibroblasts and stimulate fresh, healthy tissue in typical menopause.
Right.
But pelvic radiation fundamentally breaks that normal biological response.
Yeah, the radiation destroys the vascular network needed to cool the tissue, and it mutates the fibroblasts into fibrocytes that aggressively overproduce rigid scar tissue.
Applying intense 42-degree heat to a biological landscape that cannot cool itself and is already prone to runaway scarring. I mean, it turns a heavily marketed cure into a severe risk.
It really does.
It's the ultimate example of why personalized medicine isn't just a marketing buzzword. It is a strict physical necessity.
Because as our cancer survival rates beautifully improve, with millions of pelvic radiation survivors living longer, fuller lives, we are entering a completely new era of survivorship medicine.
Yeah.
The medical community is no longer just focused on curing the cancer. We are focused on the quality of life decades after the cure.
And that leaves us with a critical thought for you to take away today. We started this deep dive talking about the expectation of a universal fix.
Right.
The comforting idea that a machine that heals one person will automatically heal another. But as the multi-billion-dollar aesthetic medical industry continues to push the boundaries of so-called rejuvenation, how can we as a society and as patients better protect our most vulnerable populations from treatments that ignore their unique biological histories?
Well, that's the real challenge.
It's a question of prioritizing deep medical reality over a quick-fix marketing promise.
A vital question for the future of survivorship, absolutely.
Well, thanks for joining us on this deep dive. Keep questioning, keep learning, and we'll catch you next time.